Hello, everyone. My name is Taylin Washington Harmon, and I'm the clinical trials editor here at blackdoctor.org. And a big part of our mission at BDO is not only to provide Black America with only the best healthcare information, but it would also be remiss if we didn't talk about times where medicine has sort of missed the mark. So that's why we're discussing today medical mistrust in clinical trials, honoring the past and embracing the future. So our esteemed panelists today are going to delve into some of the complex reasons why Black America very much so has a mistrust and a distrust in the medical industry, particularly around clinical trials, and what we can do to really rebuild that trust so that we can make informed decisions regarding our health and our future. So I'm going to introduce our four esteemed panelists who I will be moderating their discussion. So I'm going to start with Dr. Bishop Deidre Parker Jackson. She is the founder of the nonprofit Vision Makers Ministries, and I am my sister's keeper, the online women empowerment group. She's a summa cum laude graduate of Tuskegee University and served as a two-term president of the Tuskegee-Macon County NAACP. And she plans to use her experience and research to inspire others to become voices for her two grandfathers, Andrew Swint and Vertus Pollard, and the other 623 victims of the United States Public Health Study of untreated syphilis in the Negro male that was conducted in Tuskegee and Macon County. Happy to have you here, Bishop Parker Jackson.
Thank you.
Our next guest is Dr. Kimberly Gregory. She is the Vice Chair of Women's Healthcare Quality and Performance Improvement in the Department of Obstetrics and Gynecology at Cedars-Sinai. She's also the Director and Fellowship Director of the Division of Maternal Fetal Medicine and the second endowed chairholder of the Helping Hand of Los Angeles Miriam Jacobs Chair in Maternal Fetal Medicine. She has served on numerous regional and national advisory boards and committees, and she is currently serving as the chair of the ACOG Women's Preventative Service Initiative Advisory Board and Southern California Maternal Mortality Review Committee. Happy to have you here, Dr. Gregory.
Good afternoon. Thank you for having me.
Our next guest is Dr. Adam Biggs, a historian of race, medicine, and civil rights. His research explores how early 20th century Black doctors used professional medicine to advocate for racial justice and examine how understandings of academic and professional merit are shaped by racial policies. His book, titled Strange Cures, Black Doctors, Harlem Hospital and the New Negro in American Medicine, 1919 to 1935, examines the role Black doctors played in the desegregation of Harlem Hospital. Happy to have you here, Dr. Biggs.
Happy to be here.
And last but not least, our other esteemed panelist, Dr. Kirsten Moore-Sheely. She is a research assistant professor in the program of the history of medicine at Cedars-Sinai. She holds a PhD in the history of medicine from Johns Hopkins University, as well as a certificate in global health from the Johns Hopkins Bloomberg School of Public Health. She specializes in the history of public health in East Africa, focusing on the ways African populations have engaged with and shaped the development of global health interventions. Happy to have you here, Dr. Moore-Sheely.
Thank you so much for having me.
Great. So let's dive into it. I want to get into what exactly mistrust and distrust means. So if any of our esteemed panelists would like to tell us how would you define medical mistrust and medical distrust in this landscape?
Well, I guess we sort of, there's the way I think of it is mistrust is more global, and it's a belief that the system is not necessarily acting in your best interest, and there's some concern about that. Whereas distrust is much more specific against an entity, like a person or a hospital or something very specific that you're not trusting. They seem like they're related, but there is a subtle difference.
No, that makes perfect sense. And I know one of our esteemed guests has been personally affected by the Tuskegee study that occurred in the early 20th century. But I do want to open it up. Like, what are some of the historical events that has occurred in the Black community that kind of encourage that mistrust and distrust that we face?
there were several different situations. The most notorious one that most people hear about and talk about, and really it brings a lot of fear to people, especially when we had the coronavirus pandemic, um, as far as getting vaccines and taking part of clinical trials, was what happened in Tuskegee and Macon County. For over 52 years, a stigma has been placed on the city of Tuskegee and Tuskegee University because of the unethical study that took place for 30 years, from 1932 to 1972. Tuskegee did not conduct the study. However, whenever someone says something about the study of syphilis, they say Tuskegee. There's no evidence that anyone from Tuskegee knew that the 625 men were being victimized. The United States Public Health Service conducted the study. And so, and what happened was, it was not just a syphilis study, it was a study of untreated syphilis.
Exactly.
It was a study of untreated syphilis. And what the intention was to see how syphilis untreated would affect the body naturally, even to the point of the body decaying. And so my aunts, my grandfathers, and none of the 623 men, 625 total, none of them knew that they had syphilis. They were not told they had syphilis. That's the first thing. Well, one of the things, it's several, but I'm going to say a few of them. They were not told they had syphilis. They were told they had bad blood, which could mean any number of illnesses. And then, even when syphilis was made available, it was public knowledge that syphilis was a treatment and a cure. The United States Public Health Service withheld penicillin from my grandfathers and the other men who had syphilis. Now, let me note something, that one of my grandfathers did not have syphilis, the other one did. But whenever someone contracted syphilis and not have it already, they moved them to the untreated group. So even when Peter Buxton was telling, United States Public Health Service, say this is unethical, it's wrong, the 1969 Ad Hoc Advisory Council deemed the study where it should continue. So it did continue for 3 more years, even for 3 more years. So the bottom line is, if the reason why so many people don't trust clinical trials and they don't trust doctors, especially so many African Americans, is because Tuskegee and Macon County was a mecca of Black people who were thriving. And so most people, when they think of somebody being mistreated, they link it to Tuskegee. And they say Tuskegee, but they don't say it happened with the United States Public Health Service. And that's where it happens. So they don't think that if someone is a Black doctor or somebody has a Black business or something, that they could provide quality care. And then they don't trust white Americans, because the researchers were white Americans who came to a Black community. So that's where it actually started, because they don't feel like they were going to get treatment. However, the difference is, my ancestors were not treated, but with clinical trials now, you have informed consent, and people will get treated.
That's good. That's really good. I do want us to delve into. Oh, I'm sorry. Continue, Dr. Biggs.
Well, I would just say that I mean, some of the sources that I have found, I think run against some of what Bishop Jackson is saying, which is to say there is evidence that Black physicians at Tuskegee Institute and Black administrators at Tuskegee Institute, people like Eugene Dibble, Robert Morton, and these are collected in the Tuskegee archives. There are letters that have been published about this. They did know what was going on in Tuskegee. They were contacted by the Public Health Service, the U.S. Public Health Service, and they were informed about what type of research was going to be done. They were informed that it was intended not to be a non-treatment study, but that they did see this as an opportunity to get on board with the USPHS because the government brought with it substantial resources, and they also saw it as a valuable opportunity for Tuskegee Institute to build up its research profile and to gain some experience for a lot of its practitioners. I think a lot of people at Tuskegee Institute at the time, and I think we can say a lot of people at the USPHS at the time, saw this as a good faith effort. I think our understanding of it changed substantially as a result, not insignificantly, by the civil rights movement. I think in the wake of things like, for example, the Nuremberg trials, but also civil rights activism of the 1960s, people took a very different look at what was going on here and began to reframe it, right? And Tuskegee became a reference point for bioethics in a much broader kind of sense, right? But I think we often sort of give the Institute too much attention in terms of looking at this as a unique example of racial exploitation in medicine. I think what we actually find, disturbing as it is that it's much more normative in the profession than we'd often like to acknowledge. And that what was a very normative conversation that went on in the 1920s and the 1930s came up around questions of this type of scientific exploitation in medical practice. And one example of this is just the 1926 Pulitzer Prize, which was given to Sinclair Lewis for his novel titled Aerosmith, which was a story that got published in, like I said, in 26, but then also gets turned into a movie in the 1930s, and then goes on to get sort of become really a normative part of American medical education for really decades to come. And in that text, what we see is that main practitioner struggling with balancing the ethical considerations and the ethical kind of requirements of science that often require scientists to be, you could say, callous to human life at times. And this is sort of weighing the benefits, the moral benefits of it versus the actual process and practice of it. I think we also don't want to do the people at Tuskegee and the men involved in the study a disservice by saying they were somehow unaware that these types of exploitative practices could be embedded in medicine, right? Black doctors had, Black patients long feared the medical profession as an instrument of exploitation. And they were very aware that medical students and medical schools often went into Black cemeteries, and particularly poor cemeteries and burial grounds, and would exhume bodies for medical experimentation or medical training. And so there were already embedded fears. And even in Tuskegee, Alabama itself, about 10 years before the study took place, there was a significant controversy that took place over the founding of the Veterans Hospital, right? So the U.S. government was building a Veterans Hospital that was for Black veterans in Tuskegee in the wake of World War I. And tensions emerged about who was going to run it, if this would be run by white physician administrators or Black physicians. And there was a push to get Black physicians as the representative administrators there, because there was a sense that they would do better by the Black soldiers who would be treated at the hospital. So it's not as if there was a sense of sort of, these weren't just dupes. These weren't just people who had no idea about what was kind of going on in medicine at the time. And I think it's a much more complex story, but it really is a much broader statement about how practices of racial exploitation and sort of extraction, we could say, are really embedded in scientific practices that are really fundamental to the profession of medicine, even then and today.
When Dr. May I address, because he said there were some discrepancies, and thank you for saying that. I am saying an indictment is placed on the city of Tuskegee, meaning the citizens. I'm talking about the citizens. When I say that, I'm saying there's no evidence. When people say the Tuskegee study, they place an indictment on the actual city. Most people are not talking about Tuskegee University, because it was not Tuskegee University then, it was Tuskegee Institute. And it was not Tuskegee Institute that conducted the study. The study was conducted at John Andrew Hospital. So that's what I was saying, Dr. Biggs, was as a citizen, a former citizen of Tuskegee, being raised in Tuskegee, Macon County, as a citizen, as a descendant of the victims, when people say the Tuskegee study, they are indicting the city of Tuskegee and the citizens. That's what they're doing. And I'm saying nobody, I don't have evidence that anybody that was a citizen or somebody that lived in Tuskegee had knowledge that my grandfathers were victimized. That's what I'm not talking about, the actual doctors and people, because yes, the researchers, they definitely were wrong.
Apologies to interject. This is of course a very riveting conversation, just semantics, and of course we don't want to place too much blame on the people who were actually victimized by this situation. But to somewhat bring it back to the present, Dr. Gregory, I do want to ask you, just kind of as a practicing medical doctor, what are some concerns that you often hear from your Black patients, especially given this landscape of mistrust in the medical industry?
I think that a lot of it is just belief, right? Like even when the COVID vaccine came out, the party line is, well, let's see other people take it first, the wait and see. And then once you actually sit down and explain to the best of your knowledge some of the rationale behind things, and you build trust one-on-one, you can frequently get people to participate and or in this case take the vaccine. But it does take some time. It's not you can't just walk in and write a prescription. You definitely have to spend time and develop a relationship.
No, I wholeheartedly agree on that. And I do want to bring up Dr. Moore Sheely, whose work is global. How do you see the impact of medical mistrust on a global level, especially given your work in East Africa?
Yeah, so I think we see, looking globally and in Africa in particular, some of the same issues and problems arising and some of the same historical legacies coming in to shape people's suspicions and kind of distrust of medical research in the region. And so, of course, there's a long history, especially during the colonial period, of European and American scientists coming in to conduct clinical trials across the continent and in other regions of the world as well, and usually through coercion, getting people to be subjected to painful procedures or take sometimes very highly experimental, highly toxic drugs, for example, that were kind of allowed under the conditions of political repression of colonial rule. And, some of these scientists didn't always state any kind of racist ideas explicitly, but you can tell by the way they, treated and talked about research subjects that frequently African populations participating in these trials were not thought of as kind of equal beings. They were treated as kind of guinea pigs, and that idea and feeling that people are just being used as guinea pigs on the continent really persist, especially because many of the treatments, if they are successful in terms of their medical efficacy, for example, they aren't available to populations in the area. They're tested and then they never, they're not really integrated into medical care, into the what is available to these populations. So that also kind of feeds suspicion that this research is merely extractive and that populations are merely being exploited. And you can hear people talking about that today. So the language of colonization and colonialism is still rampant when thinking about African populations and medical research and their relationship to that, even though formal colonization is not here today, but that language still persists. There's still a lot of feelings that people are merely being used as guinea pigs, and actually people are very aware of the situation in the U.S. And the discrimination against Black Americans in the United States, and that also fuels this kind of suspicion that particularly white Euro-American researchers have ulterior motives in this research. And so there are many things at play here. There's ulterior motives, suspicions of that medical research is actually harmful, but also that it is merely being used to benefit populations elsewhere. That it's fine, that scientists think it's fine to do experiments on us, but they're not really doing it for us. That's a very persistent idea. And even when populations can access medicines that they might not otherwise have access to through clinical trials, again, those medicines aren't there afterwards. It's a very time-limited access. And that definitely feeds back into the idea that this research isn't conducted for the benefit of African populations, that it's conducted for the benefit of other people. And so,
Right.
so we see some of the same issues coming up.
You brought up such a good point about this worry around this experimentation, or this medicine is being done on us but not for us, whereas in clinical trials, like, it is very important that we do have individual studies that show how does it affect Black populations, because certain medicines may not always work for certain populations. We've seen this throughout medical history. So I want to open up this question to make it a little bit more broad, is like, how can we sort of shift the conversation around how clinical trials can be done for Black benefit without the fear of this is an experimentation, or this is only taking from us rather than helping us?
I think one way is to start with diseases that are highly prevalent among the Black population, right? And that way, or that not necessarily prevalent, but the disease course is worse, or so that there's a need, and the community agrees that there's a need, and that it's a collaborative process.
I think one way too, also, as I go out and I speak to African Americans, and I was trying to encourage different people from state to state to participate in clinical trials, and I continue to do that. One complaint that I get from a lot of people is the esoteric language, the terminology that's being used when people from the medical field go out and try to convince just regular citizens to partake in the clinical trials. Is they'll say they're talking above my head, and it makes me feel, that I'm not intelligent. I didn't go to college, I didn't get a medical degree. So if we can kind of soften the language, and even though we may have to use medical terminology and acronyms, but if we could find ways to actually explain to regular citizens without making them feel like they're ignorant or dumb, like my grandfathers were treated just because they didn't have the law degrees and doctoral degrees. They weren't ignorant, but yes, they were guinea pigs, but they were not ignorant. They didn't have degrees from Harvard and Yale, but they did go to school, high school. They did graduate from school. So we have people who we want, the great masses who have graduated from high school, but they didn't get college degrees, so they don't understand that terminology.
No, that
And
makes perfect.
if I can if I can just amplify some of that, I want to say, even folks with college degrees a lot of times don't understand a lot of medical terminology, right? I'm not going to go into my own personal experiences with this, but I'll just say that, and this is one of the things that comes up that led to this sense of distrust that goes back to the study, which is that the term syphilis wasn't used to describe the illness to the men involved because it didn't necessarily translate to them. So they would talk about terms like bad blood. It became very difficult to use these sort of scientific medical terms in ways that were that sort of had the required and necessary amount of sort of specificity to make them feel transparent, I want to say. But I also think in that same vein, the more we can do to diversify and to really open up the doors, you could say, or at least the ranks of the medical profession to a greater diversity of people has a lot to do with our ability to kind of push medicine, or sort of to bring medicine to a broader swath of the population. I think, we 2% for most of the 20th century, 2% of American physicians were Black. Okay, which meant that the disproportionate number of physicians that Black patients would attend to were white. But just anecdotally, and Dr. Gregory kind of spoke to this already, if you go back and you look at the autobiographies of Black physicians, like it's almost in every incident, you will see at least one example where the physician mentions encountering a patient who doubted their capabilities. And what they are very good at doing, what they become very adept at doing, is gaining and building and cultivating a sense of trust. And I think this is a set of shadow skills that we see Black physicians acquiring over the course of their training and careers, because they are in these environments that constantly doubt their ability, doubt their intellect, doubt their capacity to actually do these jobs. And so they are constantly assuaging these doubts. They are constantly building trust. They are constantly demonstrating their ability to serve in this role well. And so I think when we find ways to bring a more diverse population into the medical field, we increase our ability to actually be more persuasive in getting our more diverse populations to actually participate in these kind of research studies.
I do want to talk a bit about clinical trial design. Like, is it possible for us to even modify the way that these clinical trials are conducted to make Black folks feel safer and more confident in what they're going into? I would love to hear from our experts on that thought.
Well, I'll just build on what Dr. Briggs was saying, is that having research personnel who look and talk like you is helpful. Being part of the planning process, there's more and more of this community-based participatory research language that's going on, so that you're actually asking some questions that the people want answered, not just the questions that the investigator wants answered. And taking into consideration time, time is money. And so if you're going to ask somebody to be in your study, they should be paid to be in your study. Taking consideration that if they work, then you have to have the hours available for them to come after work. So there are a lot of things that are sort of forced into our system because that's what the medical system wants. That isn't conducive to the participant. And the more we engage them and include them in the planning, the more likely we'll be able to solve some of those barriers.
Yeah,
Yes.
if I can just build on what Dr. Gregory said, I think community involvement in particular, as well as kind of representation among the staff, research staff and PIs is very important. And I think also thinking about after the trial, continuing to maintain relationships and engagement after clinical trials are over, I think is also very important. So you don't perpetuate this idea that, we had this time limited kind of access to healthcare through this trial, and now the investigators have forgotten about me, have forgotten about us. And I think people who do have positive experiences by participating in clinical trials, if they feel that there is a relationship and that there is investment in their perspective and trying to help others understand the benefits of participating in a clinical trial, that's very valuable, and that should be invested in, those kinds of relationships and that kind of engagement following the trial, not just before and during, I think.
And also making sure that they know that it's bigger than them. That participating in the clinical trial is helping them help all of humanity. And diversity in clinical trials is so critical because what helps and what works for one group of people with a certain DNA or in a certain socioeconomic area, and how drugs and different kind of medications can reach those people in a certain area, somebody else in another area may not be able to go to a clinical trial. So to let them know that, hey, you may be one person, but the impact that you're going to make in this clinical trial will be globally.
Yes, yes.
And
I
I mean, if I can just add another part to this in terms of like pushing a level of transparency, I think, and one of my shticks is that I think we need to be a lot more transparent about the role that the university plays as an agent of exploitation in these moments, right? So a lot of what we kind of see, I want to say a lot of how we tend to think about universities' role in these types of study often is portrayed as beneficent, right? That it's just about contributing to the growth and development of knowledge, when a lot of times universities are also not necessarily good faith actors in the communities in which they serve, right? They exert a disproportionate amount of influence over land values, a disproportionate amount of influence over like local governance when they don't have a heavy tax burden. They also, I mean, we give them sort of a pass on the ways that they are complicit in different forms of racial exploitation and exclusion. And I think the more we can be transparent and the more we can own that type of complicity, I think it puts us as better good faith actors when we are recruiting people to take part in these kind of endeavors. That is to say, yeah, I'll leave it there.
No, that's a great place to lead into our next question is how can healthcare and doctors writ large kind of bring this awareness around the benefits of clinical trials, outside of the doctor's office? Because here we're having this conversation, on blackdoctor.org. I'm sure a lot of people in the medical industry are viewing this, and even some people who aren't in the medical industry are viewing this. But how can we have these conversations a little bit more broadly? And how can healthcare professionals bring these conversations more broadly to make it a bit more comfortable to talk about?
I can say that interestingly enough, recently I've been involved in a couple of trials where we've actually gotten our most successful recruitment through social media. Now, I'm sure there's a bias in that, and there's always a bias in that. People who participate in research may not be like people who don't participate in research, but what is novel in that is realizing and appreciating that people who want to get involved get involved. Now, not everyone is on social media, and so it's not a perfect fix, but we have been very successful, and in some sensitive ways too. Like if you're looking for someone with say depression, or if you're looking for someone with substance use disorder, those are not necessarily things that are always front and center in a doctor's conversation. But if you're recruiting that patient population and somebody comes across it in a neutral, safe way, we have found that to be helpful.
No, that's great. Bishop Jackson, I do want to ask about kind of your experience, as somebody who, to the general person, they would think, oh, why would she be an advocate for clinical trials if she has such a strong connection to what happened at the Tuskegee study? What kind of made you passionate about this and about rewriting the narrative?
Okay, my mother, the late Joyce Parker Pollard Williams, she and Lily Head and some of the other descendants, they got together and they formed what we call now Voices for Our Fathers Legacy Foundation. And what they got together to do was we go out and do research. And we make sure we try to find as much truth as we can. And I love Dr. Biggs. I expect to have conversations with him later on, and all of you on the panel, because what we do, we debate, we conduct our own research individually and collectively, but we want to make sure we're putting the truth out. That's a lot to do with gaining trust, making sure we're speaking the same language, and the language that we're speaking is truth, where people can go and find the truth for themselves. So what we do, we partner with other people We partner with different people in the healthcare, in the people who family members were, like, say, for instance, financial contributors to the study that was conducted in Tuskegee and Macon County by the United States Public Health, like Meal Bank Fund. We have partnered with them. I'm talking about, he's like an uncle to me. This is the honest truth. Building real, genuine relationships with people. With the CDC, they've taken ownership and they say, yes, we conducted the study. So they've changed even on their websites and in different future documents and publications, and they put their names first and say, that United States Public Health Service study conducted this study and everything. So what it is like Dr. Biggs is saying, I know I say his name a lot, but he's telling the truth about everybody who was involved, everybody who knows what's really going on. We're just going to have to tell the truth. We're going to have to be transparent. And there's no reason for us to go out and try to convince other people to give to our foundations and to participate in clinical trials if we're withholding truth. So we all have to make sure that we actually genuinely love humanity and we are out there advocating for humanity. And like Dr. Sheila said, and not just out there just to get the little, information we can from them now, and then we don't know them anymore, but be sincere. And like Dr. Gregory is saying, making sure that when we foster these relationships, that is community based. It's community based relationship. So that's what we're doing. We regular people. When I say regular people, I'm saying people who don't participate in anything. We get them to come and meet with us and talk with us and ask us questions, because some ask, say, we heard that they were injected. We need people to ask these questions if that's what they're thinking. And so that's the way that we do it. We make ourselves available at voicesforourfathers.org. You can go on there and you can see all kind of ways that you can actually engage. And guess what the $1 million thing is? Everybody can be a member. You don't have to pay to be a member. Everybody can help us spread the truth. And the last thing is the National Institute of Health has created a monument, and they've apologized, and they created a monument for our ancestors, because they wanted to let the world know, say, hey, you can come and visit us and you can come and find out the truth. Please go to the National Archives in Atlanta and do research and look at the thousands and thousands of actual documents like we do every year, several times a year. So that, and don't confine ourselves to say, okay, this is healthcare. This is, we're community advocates. We're human beings. So we don't want this to ever happen to anybody of any race.
Definitely.
And just add, I think, in the sense that asking people to participate in studies that they may not be able to reap the benefits of, expanding access to healthcare, particularly in the U.S., would not be a bad way of sort of recruiting more people into these kind of studies. But just to, Bishop Jackson, since you sort of mentioned it, I think just to kind of amplify this, the Meal Bank Fund provided the burial insurance to, or the promise of burial insurance to the men who were involved in the study, right? The U.S. Public Health Service initiated the study, and we get an apology, from Bill Clinton and the USPHS, and like you said, CDC and NIH are there to amplify this study. And one of the things that that bugs me is that we haven't gotten an apology from Tuskegee University for the role that it played in this study. And I think when we talk about a fully loaded cost accounting of acknowledging our complicity in these moments, I think having universities acknowledge that they have taken part in these kind of endeavors and that they recognize it, I think is an important part of transforming the type of narratives that we tell. We have to be authentic. We have to be forthright. We have to, essentially be repentant about our complicity in these things if we want people to actually trust us or have a reason to trust us.
Totally understand.
Yeah, if I can just build on what everyone has really been talking about so far in terms of transparency on the part of institutions conducting research. Some investigators may come to an institution being fairly new without a deep knowledge of the institution's past in a particular community and their relationship with a particular community. And so I think transparency about what the institution that you represent, what their relationship has been like with the surrounding community, particularly in terms of medical research and kind of unethical practices in the past, I think is also very important, especially, for new investigators who might not be so familiar with that history. I think it's worth doing some digging and, again, being very transparent about that.
I can tell a story.
Dr. Biggs, I can understand what you're saying. It's just like with President Clinton. He didn't have anything. He did not he didn't have anything, but he made an apology on the behalf of the United States government.
Right.
What you're saying is whoever the president is now, he wasn't there then, but because researchers were there, the Tuskegee Institute, the president at the time, allowed the study to take place at John Andrew on Tuskegee Institute's campus, then the president should say, you all, we apologize that this was allowed to happen to your ancestors on this campus.
Yeah, absolutely. I mean, for folks that, I think most folks are probably, at least on the panel, I know, recognize it, but for in the audience who may not, Tuskegee University is a historically Black institution that was built with the intention of advancing the interest and needs and addressing the interest and needs and promoting uplift of African-American communities in the Jim Crow South. So it was a community that was committed to the cause of serving Black folks and addressing Black folks' needs at in an extraordinarily oppressive environment. And I think, like, recognizing that, and that I think that is to acknowledge that one can be complicit even when one is aware that this type of violence is sort of embedded in the American social structure is really an important kind of way to acknowledge that a problematic kind of element of this process. That is to say, when we say, we are still committed to serving Black folks, and that is to say, we acknowledge when we've been complicit in things that that were violent against Black people. It doesn't necessarily, I think that kind of acknowledgement, that kind of reckoning, that kind of recognition, it gives us a type of transparency. It gives us an authenticity where we say we're still committed. We're not going to disrespect people by engaging in acts of denial and pretend like these things didn't happen. It's that kind of transparent. I think that type of transparency is radical. I think that type of transparency can be transformative and very meaningful in ways that lead us to ask very different types of questions about what was sort of going on in this particular moment and what's going on with medical research then and today.
You bring up a very good point, Dr. Biggs, about taking not personal responsibility, but just taking ownership of how we can be complicit in some of the situations that, have placed us in this landscape of medical mistrust and distrust. So I want to get into, I guess, where's the onus on the Black community for making sure that we are participating in, medical research so that we don't have another Tuskegee in the future? Is there an onus on us, or is it purely us making sure that as people in the medical industry that we work towards making sure that another situation like this never occurs again?
All of us are responsible, whether we're in the medical industry or not, but definitely the medical industry. But like with Voices for Our Fathers, we all take responsibility to make sure that this doesn't happen again. So that's why we partner with you all. And that's why I invited myself to meet with Dr. Biggs one day, if it's on Zoom or whatever, because we all have to know, everybody, those of you who are watching now, we are all responsible. Even if you never went to school, even if you never graduate from high school, whatever the situation is, if you retired or whatever, we are responsible for conducting research. We are responsible for making sure that we don't put out false information, so that if clinical trials are trying to come to your neighborhood and your city, let's stop making jokes about Tuskegee, because this is serious. And let's start actually understanding that we're talking about human beings and lives. So clinical trials help save lives of people who have cancer, HIV/AIDS, heart disease, not just syphilis. So we have to not just keep talking about Tuskegee as in a negative way, because when we do, then it's deterring people from who have other diseases from wanting to participate in clinical trials, or people who are healthy from wanting to participate in it, because they feel like you're going to talk about them too. Because guess what? I promise you, during the coronavirus, during the pandemic, I'm not going to get, they even comedians were doing it. I'm not going to get the vaccine, because you know what they did in Tuskegee. I made sure I went and got my vaccines and my boosters, right? And then I went and told people, and I explained to them. And remember, I'm not in the healthcare field, but I'm in it now because I'm an advocate, and I'm an all-around advocate. But yes, Dr. Biggs, you're on the edge of your chair. Want to say something? Go ahead.
So now I forgot the question. This is what I was going to say. No, I got it. So this was the story I was going to tell. So the first time I got COVID, I was serving as a postdoc at Johns Hopkins, and two things happened, right? Because they have this huge, infrastructure set up. So I would get regular text messages from the Department of Health asking me how I was doing. And you would just send these, affirmations about it one way or the other, which I actually found, they were automated. I found them strangely comforting. And when I was better and they were gone, I missed them. The only, though, notes and text messages that I tended to get from Hopkins, though, were asking me if I wanted to be in a research study. And every time I got those, I turned them down. And I turned them down for many of the same reasons I think that other Black folks have turned them down. Is that partly I didn't want to be involved with it, partly I didn't want my information to kind of get utilized. I didn't have there wasn't a sense of transparency with it for me that made me want to feel like it was a project I want. I mean, there was a lot of distrust that I had. I got a PhD, okay? You know what I'm saying? It's not like I haven't read about this, studied this. A lot of these people I know, you know what I mean? And I didn't want to take part in it. I think when I think about when I think about the types of changes that we need to, well, the question was how we should be accountable. I think Black communities can be accountable by holding these institutions accountable, by pushing them, and I think by movement politics, by pushing them to be more transparent in their dealings, whether that is in our local communities, in these efforts to gentrify areas, to colonize local urban communities, and move Black folks, away from campuses, in the effort to be more transparent about how clinical processes are taking place or research is being conducted. I think I think that is the way that I want to say in a democracy we can exert our greatest type of influence, is by thinking in a collective kind of way. And I think we do that by embracing our Socratic sensibilities, right? Asking very basic questions like, why are we doing this? Why is this being asked? Who does it benefit? What's the motive behind it? And how can I get some more information from it? Why should I participate in this? I think those very basic that process of ongoing, rigorous, and continuing questioning is a valuable way to build a democratic sort of consciousness that allows us to be more effective agents.
And I do think that it's important to let people know that there is an institutional review board, an IRB, where all clinical trials have to, meet a minimum standard of an audience of not only subject matter experts, but most IRBs actually also have community members who are representative of the lay public. And they're asking those exact questions, does the benefit exceed the risk to justify this study? And so to some extent, there is a public watchdog. Now, it's not as rigorous on some of the international studies, and that is a problem that has been brought up. But in general, if you've gotten a study approved in America, somebody has thought about the ethics of it and the risks and benefits of it.
These are all really great answers. Thank you. I do want to make sure that our viewers take an opportunity to ask any of our panelists any questions or concerns that they may have in the comments as we're coming up on time. So please be sure to do that as you're watching. But I do want, as we're starting to close out, I want to know, like, what do you primarily want our listeners and our viewers to take from this conversation today? What action do you think that they should be taking after watching this debate, watching this riveting conversation? What actions should they be taking?
As a bishop, I'll be brief. The Bible tells us to study to show thyself approved unto God. So we need to make sure we conduct research, find out information, foster relationships with people, and love one another. And make sure we remember it's all about humanity, and it's all about us progressing and healing from trauma so that we can triumph together.
Well, that's a great place to end. I don't want to go behind that. But I would say that participating in research is very personal, and it's very one-on-one. And if this project isn't the right one for you, maybe the next one will be. And trust and believe that most of the healthcare you're getting right now, somebody did an experiment to get us here. And so if you look at it from that perspective, only more can come from the greater good in us participating where we can and feel comfortable.
And I think I would say, I mean, the takeaway that I would have is just the importance of being comfortable asking questions. And I want to say just, like rigorous, critical self-reflection when taking part in these kind of endeavors. I think for me, I'm much more comfortable with the idea of being transparent about there being sort of conflicting sort of moral tensions within this, right? So we don't generally tend to see medical researchers taking part in medical endeavors that don't also benefit their own professional advancement in some kind of way, right? And so recognizing that we go into these sort of situations with an awareness that there are moral tensions embedded within it, and being willing to sort of ask about those, and being willing and comfortable with the idea of encountering those, I think put us in a position where we can be more effective agents and advocates for ourselves. But that is to say that also these two things can be held, in conjunction. People can be working in good faith and also in ways that can be exploitive. So people can very well be involved, be interested in serving the public good, but also be interested in professional advancement. And that these things may very well seem like they are contradictory, and sometimes they may very well be contradictory, but they exist in a type of devil's bargain, is what I would like to say. And that when we recognize that, it allows us to move, I want to say, with more agency and perhaps more effectively.
Yeah, and the thing I would kind of add to what everybody has said is that some of the issues of mistrust and distrust in clinical trials is very much connected to issues with the larger healthcare system in terms of access, not only to doctors, but then to therapies thereafter. And so I think it might behoove us all, especially those maybe on some more of a policy-making side or, that kind of side of things, to think about this issue not just in isolation in terms of medical research, but how can we address this issue in conjunction with some of these larger issues with inequities in the healthcare system more broadly. And those are huge, large issues, but to understand the links between them, I think is very important if we're going to keep making headway on the issues of representation in clinical trials.
Definitely. I agree that medical research will always be necessary. It's what brought us to the current life expectancies that we have today, to the modern advancements that we have, why so many people live long. Medical research will always be necessary, but also healthy skepticism and healthy question asking is always important. And that's why we do what we do at blackdoctor.org, is to bring these conversations to the table, to talk about how Black folks can ask these questions in a safe manner, but still make sure that our health is placed at the utmost pinnacle. So I want to thank all of our esteemed guests for being here, for taking part of this wonderful conversation. I definitely learned a lot. I really hope that our viewers learned a lot. And thank you again. And I hope you all have a happy holiday season.
Thank you for having us.
Thank you for having us.
So
Great
much.
discussion. I enjoyed